Okay, guys, so yeah, I'm fairly new at coding, urology, and multiple E&Ms by different departments, and surgeries and procedures and tests and stuff. So, um, the good thing about this is that a previous employer, even though they were a multi specialty clinic and they did professional charges. They also did a lot of tests and a lot of, different E&M, different departments saw the patient in the same day. So this isn't new to me, but because the place that I worked at didn't have like a billing department and a coding department that had like policies and procedures already in place, we were doing a lot of trial and error billing and making policies and procedures from our mistakes. And the mistakes that we made wasn't always revealed to us because the um I guess the faculty, the board, they were trying to understand the mistakes, find the trends, try to correct it before they came back and told us like the trends that they were seeing and the mistakes that the coders and the billers and the providers were making and opportunities to correct it. So a lot of my multi-specialty tests, labs and stuff, billing knowledge was just me learning the policies and procedures, the guidelines in the coding book, and applying them and trying to research different insurance policies either before I submitted the claim when I was confused about like what modifier to use, what situation, um, you know, sequencing situation I should be using, and if some of these procedures are included in unbundling. So learning that with these new procedures, tests, techniques, you know, as well as understanding like the rules and the different nuances in all of this is definitely something that I'm still learning and I'm still developing. So with that being said, I'm gonna stop rambling and we go get through these charts. Now, I don't know how many charts you have to be able to code per hour for surgical tool coding guidelines or policies for each employer. My employer did not tell me any yet. I'm probably going to ask that on my next, like, whatever, get together or whatever, one-on-one check-ins. But right now, it's just about me learning, gaining speed, understanding my denials, and understanding how each provider documents. So in the department that I'm working in currently, they probably have about 5 or 6 providers that sees patients in this clinic. And some of them are APRNs, some of them are MDs, and I think that's it, APRN and MDs. They also are teaching. So they have some residents and some students that's working there. And they also have assisting surgeons. So some of the things that is new to me is using modifier 57, which is the decision to do surgeries on the same day as an office visit. I never, let me make sure that's right, because I used it once and I was like, godly. Oh. Yeah. 57 modifier is fairly new to me. Like I know about it, but I didn't have to use it in my previous specialty billing. So, now I'm seeing it and I have to be mindful of that modifier. Also, modifier 26 is pretty new to me because that's just like reading the test and stuff like that. So I never really used modifier 26 that I can recall, even in that clinic that was the multi-specialty clinic that I told you about. I actually made a video discussing that experience. That job was hell, but it taught me so much. It exposed me to a lot, and this is one of the instances that it exposed me to. Using modifier 26 is actually defined as the professional component. The professional component is outlined as the physician services, which may include the technician supervision. So they may be watching the technician. They may be interpreting the results of the written report. As long as the provider did not perform the test, they only are interpreting it, then you're supposed to use modifier 26 on those services. Now, like I said, I don't remember using maybe I didn't have to. I do know that facility, that clinic, they did do tests and had an E&M visit, possibly on the same day, and maybe even like some psychotherapy visits, maybe, some stuff. But I don't recall having to put modifier 26. So I don't know if it was something that was built in our system. It could have been. Or if it was just, like I said, something that we missed and it was an opportunity for us to, capture that denial. But anyhow, I do know now to use it and what situation to use it in. That's new to me. Let's see. What else is new? I don't know. But let's just see as we go along. So what I am learning, in addition to surgeries, of course, they do E&M visits. And I am learning that E&M visits is always going to be a little challenging, only because of the interpretation. It's very hard for a coder, or at least for me as a coder, to switch my brain to levels. To switch my brain to levels of E&M services. So, in one clinic, you might have something that a provider may not see often, and it may, in fact, like be more of a medical decision making on that provider's part, to do more of a challenge of medical decision making on that provider's part, because it's a component that makes it a little bit more challenging than in a clinic that sees something regularly. So for example, I'm thinking of maybe like in dermatology, they deal with skin stuff, and they do procedures based on acne, rashes, situation like that. So they may see rashes and different infections or whatever, and may say that the problem is normal. It's something that is always seen in that department. It's something that doesn't take a lot of medical decision making for them to come up with a diagnosis for this problem. So they may code it as a level 3. That same situation could be seen in the clinic where the child, in urology, for example, they may see this child in urology for a routine checkup because they've been seeing the urologist for however long the issue was, but they happen to have a rash, and it's kind of bad. But in dermatology, they see it all the time. They know this could be just like a diaper rash or something like that, or a growing rash or something like that. But in urology, it's in the growing area. This kid has like some kind of situation that they've been seeing them. They're an established patient with them. They're seeing them for some urological situations, but now they have a rash on top of whatever is going on. So they're trying to rationalize it, if it's rule out anything that could be related urologically at that point. And so their medical decision making may be a little bit more intense, because it takes more for them to come up with a diagnosis, and they may even have to do a referral, because it may turns out that they ruled everything out urologically. Now we just got to see dermatologically what's going on with this patient. So now I have to refer this patient to a dermatologist. So the medical decision making, it was a little bit more intense because now I had to make a decision not only to try to diagnose this condition, but to also make a decision if you need to see a dermatologist. And the dermatologist could look at that same thing like, oh, this is and they code urology would code it as a level 4 because maybe it was a lot for them to do. They had the research, whatever the case may be. They send it over to dermatology see, oh, this is routine so and so, I'm coded as a level 3. So it's very hard for a coder to switch their thinking of leveling to think about that particular provider specialty when you're not aware of the involvement of what the thought process of the provider. And of course, we can't be in provider's head to know what they're thinking, how they're coming up with their leveling. So that's why I'm like, coding E&M is always going to be a little challenging. But what I am learning to do is to, like, especially if it's something that's, not as significant as level 3 and level 4, like, okay, that's cool. Level 3 or level 4, especially if they meet the criteria, you can rationalize it. You can prove why you agree with this thought process, or like, yeah, I'm learning to let it go and not be so black and white and say, oh, it didn't hit this point. Yeah, and they didn't, like, I don't know. You have to be an E&M coder to kind of understand where I'm coming from on that. But yeah, if you agree, drop something in the chat to let me know I'm not alone, because if you even understand this ramble. But I digress, and let's finish coding. So this is an E&M visit, and this patient just saw the one provider on this day, and the doctor did a really good job at documenting out all the diagnosis, clearly picking the most appropriate specific diagnosis for that encounter. They had the signatures on there correctly, the date on there correctly. They did their soap note perfectly. Let's see what else is good. Recommendations is on here, good. Signatures is good. Communications, who all they involved in this visit. Labeled the fact that it's a follow-up visit, so it's cool. They have their diagnosis carried over. Epic is really good with showing you multiple places where the diagnoses for that particular visit could be at. And this is one of the better EMRs that I have ever worked with. I've worked with like 3M before, Cerner, All Scripts, Epic, as far as like 9 to 5. But in like my business, I've worked with Office Ally. What else? Therapy Notes. I think one more. I can't think of the name right now. So I am very interested in learning how to work in multiple EMRs. Somebody on one of my other videos asked about, in your billing business, clearing houses and software, I guess. And I'm thinking they wanted to know what softwares and EMRs I'm using when I'm billing in my billing business. And for that, due to the fact that most providers already are billing their own services before they hire a billing service or decide to outsource their billing, they usually already have some kind of software that they're using, some kind of EMR that they're using, because they have to notate and dictate and have to have, HIPAA compliant, software and stuff like that. So they usually provide a login for their clearinghouse that they use and EMRs. Also, you can file claims through the insurance company directly in some cases. You don't have to go through like the software that the provider gives you or your own billing software. You can go straight to Blue Cross Blue Shield. They will let you know how to, use their clearinghouse and how to, or the clearinghouse that they are connected with and how to submit claims. So I do know, like, for example, one of the providers that I work with, we do her claims, some of her claims, her Blue Cross Blue Shield claims through Office Ally. I think that's what it is. Hold on. Yeah, we do it through Office Hour. So I do know one of the providers that I work with. We submit her claims, some of her claims through Office Ally. They act as the clearinghouse, and then they submit it over to Blue Cross, and everything is just documented through that. And then I post everything to her software, her EMR of choice that she uses. And so we do the process that way. She has every right to use one system and have the EMR to submit it through the clearinghouse. And the clearinghouse go ahead and processes the claim and send it over to Blue Cross. If she pays for an EMR that has that capability, but this is the way she chooses to do her claims, and it's been working for us. So I would suggest, like, if you are starting your medical billing business and you are worried about billing software you have in your contract, that you will be using the software, the clearinghouse and the billing software that the provider provides. And you just need to get, because it's web-based, cloud-based, you just need to get a login and, do it that way. So hope that helps. But anyway, so we are doing just simple office visits. So the process that I use, of course, is pull up the patient, check the date of service, name, everything, insurance, everything is good on the demographics. Then, because this clinic, the patient usually will come in and have more than one visit, more than one providers for this day. So I just check to make sure that there wasn't anything else that was already submitted for that date of service, and there wasn't. And so I just go in and just make sure that I have the most accurate and specific diagnoses, that the diagnosis that's carried over for the billing is the one that is documented in the note. Make sure that all the components of the note is needed. The most important for an E&M is the medical decision making. So it's like your plan and assessment that the providers use, because that's where we're going to get our leveling from. Like, with the new E&M, the 2022-23 E&M changes, it's pretty much as a coder what you're focused on, but all the other components of the note is needed. Like, we still need to know what the patient feels in their own words. We still need to know if any of the systems has been reviewed. We still need to know what the doctor sees. And then, like I said, the most important part is the final assessment and plan. So we can get our leveling, but that gives us the whole complete picture so that we know how to accurately code some things. Because in your review of systems, in your SOAP note, you will find if you need to pull codes for long-term medication, or if you have some code also that is applicable to some of these diagnosis codes. Also, you may be able to suggest a higher level code if something is just like, you could get more credit for this, and that. Also, sometimes procedures, the provider will put the procedures like in different places of the note, even though it is part of their assessment and plan. They may not put the procedure in their assessment and plan. So you need to like review the whole note for just things like that, just things that you know in coding. So anyway, once everything is all, you verify the note and everything, you make sure all the components to the note is needed, so that the note was signed, the note is dated, things of that nature. If attestation was needed, say for instance, if they just happened to do telehealth services or they was teaching, a resident, and the resident was involved, you need to have the attestation that they were also involved. The providers need to dictate that. So that's just some of the things that I have been encountering in this department, and it's been a learning process. Definitely is a little bit more clicks on the keyboard and mouse than just regular like behavioral health or even dermatology, because it's like more intense surgeries. But when you're doing like their office visits, it's pretty straightforward. It's not much you need to do besides regular E&M coding and just looking out for little nuances, like I said, different visits on different days and possible procedures that's missed and things of that nature. So yeah, it's really nothing else. But I appreciate you guys for watching and listening to my rambling as I code some of these things. Hopefully I'll do more of these videos and we see what we come up with.